When a new client sits down for their first session, they rarely present a neat, categorized list of symptoms. Instead, counselors are usually met with a chaotic overlap of immediate complaints, hidden trauma histories, and acute emotional stress. To make sense of this overwhelming presentation, we have to push that raw information through a clinical funnel. This mechanism systematically filters a client's swirling subjective distress into structured, actionable data. Intake and assessment functions as a rigorous, multimodal matrix, deploying both formal and informal measurement tools from the very first minute of interaction. Ethical, effective counseling depends entirely on this conversion. If a practitioner cannot translate a human being's subjective chaos into a highly structured, objective clinical baseline, they cannot safely provide treatment. By mastering specific assessment filters like clinical interviews, behavioral observations, and risk evaluations, counselors build the precise architecture required to make an accurate diagnosis using the DSM-5-TR. The DSM-5-TR is the Diagnostic and Statistical Manual of Mental Disorders. It serves as the standard classification system used to identify specific conditions. The diagnostic interview operates on 3 tracks: unstructured, semi-structured, and structured. Structured interviews ask predetermined questions in the exact sequence, guaranteeing reliable data but offering zero flexibility. Unstructured interviews rely entirely on conversational skills. They build rapport but yield extremely low reliability for formal diagnosis. That leaves the semi-structured interview as the clinical workhorse. This approach provides specific, required questions to examine well-defined symptoms, but gives the counselor the freedom to adapt the sequence and use open-ended prompts based on the client's cognitive level or situational needs. One of the most vital semi-structured tools at a counselor's disposal is the Cultural Formulation Interview, or CFI. The CFI consists of 16 brief questions designed to assess the specific social conditions where the clinical issue occurs. It allows the clinician to procure information about the influence of culture on the therapeutic process without imposing their own biases or cultural assumptions. Selecting the right interview structure dictates the quality of the resulting data. It determines whether a clinician actually captures a client's lived context or merely checks off a rigid list of symptoms. Even with the right interview format, verbal assessments rely heavily on client self-report. This introduces a high chance of bias, as clients may lack self-awareness or attempt to circumvent accurate measurement due to dishonesty or shame. To counter bias, counselors run the Mental Status Exam, or MSE, a continuous baseline assessment of functioning. The clinician simultaneously observes 6 areas: appearance and mood, speech and language flow, thought process, cognition and orientation, and finally, insight and judgment regarding their struggles. The MSE is rarely a separate questionnaire handed to the client. Instead, it operates simultaneously alongside the primary verbal interview, forming a continuous secondary stream of behavioral data. Without the MSE running in the background, a clinician is flying blind. They are forced to rely entirely on what a client chooses to reveal, rather than what the client's physical behavior objectively demonstrates. Sometimes this dual data stream detects an anomaly, indicating potential harm. The counselor must immediately abandon general inquiry and pivot to acute risk assessment. If the data suggests suicide risk, the clinician directly asks about the client's suicide plan to evaluate the lethality and available means. They also assess suicide history, looking for past attempts or exposure to other suicidal behaviors that statistically increase current risk. This table displays standardized tools counselors use to quantify risk. For instance, the SAD Person Scale evaluates 10 demographic and environmental factors, while the BSSI, or Beck Scale for Suicidal Ideation, uses a 21-item self-report questionnaire to measure the specific severity of those thoughts. If the identified risk involves substance abuse, the standard of care requires the deployment of an evidence-based intervention strategy known as SBIRT. SBIRT is a sequential 3-step action plan. It stands for screening, a brief intervention, and referral to treatment. Counselors begin by screening for harmful behaviors, engage the client in a brief discussion regarding the consequences of their drug use, and finally recommend appropriate treatment based on their motivation for change. This model is highly adaptable across different healthcare settings and proves exceptionally successful at detecting substance use disorders in their initial stages, quickly matching clients with suitable care providers. In moments of acute crisis, standard diagnostic interviews fail to provide the necessary safety constraints. A client's survival often depends on the rapid deployment of these rigid, highly specialized risk frameworks. Once immediate risks are managed and the initial intake is complete, we return to the bottom of the clinical funnel. Here, all the gathered biopsychosocial and observational data is synthesized into a cleanly formatted clinical assessment report. This chart outlines the required areas to include in that clinical documentation. The foundational components include documenting the specific reason for referral, detailing the exact assessment procedures used, and providing a comprehensive history of the client's background and psychosocial stressors. Scanning down to the analytical outputs, the report must also catalog test results, summarize clinical interpretations, and provide specific recommendations detailing the necessary next steps for the client. The ultimate goal of compiling this exact data is diagnosing the client. In a clinical setting, this means classifying the client's presenting problems into predetermined categories based on the criteria established in the DSM-5 TR. Establishing this diagnosis is what allows the counselor to determine the client's prognosis, their ability to recover, and select the precise modality of treatment, whether that requires individual, group, couples, or family therapy. But assessment does not end the moment a diagnosis is written down. It requires a continuous feedback loop linking intervention and evaluation. Clinicians use progress monitoring to track clinical data session by session, ensuring they can adjust care as the client responds to treatment. Upon termination, they conduct an outcome evaluation, analyzing the full dataset to objectively ascertain the kind and extent of changes made by the client. Rigorous intake, continuous assessment, and meticulous documentation serve as the essential ethical prerequisites for safeguarding client welfare and proving the efficacy of the therapeutic process.